Welcome to the 2022 Head and Neck Cancer Survivorship Symposium developed by the Head and Neck Cancer Alliance and the American Head and Neck Cancer Society. Our session is dental care during and following head and neck cancer treatment. I am Dr. Diana Kirk and it's my pleasure to be here with you. I am an assistant professor in the Department of Otolaryngology, Head and Neck Cancer Surgery Department at the Icahn School of Medicine at Mount Sinai. I want to thank our medical panelists for joining us. That is Dr. Pamela Linder and Dr. Mike Brennan, as well as our survivor presenter, Hank Deneski, for presenting on this topic today. To begin, I'd like to provide some brief introductions. Our first medical presenter is Dr. Pamela Linder. She is a clinical assistant professor and division chief of hospital dentistry in the Department of Oral and Maxillofacial Surgery, Hospital Dentistry at the Indiana University School of Dentistry. After completing her training in Boston, she relocated to Indianapolis and is currently practicing and teaching at the School of Dentistry, with oral oncology being her primary area of clinical interest. Welcome, Dr. Linder. Our second medical presenter is Dr. Mike Brennan. He is currently professor and chairman with the Department of Oral Medicine at Atrium Health Carolinas Center. He has extensive research experience with over 150 peer-reviewed articles and book chapters, and is currently the co-PI on an NIH U01 grant examining the oral sequelae in head and neck cancer patients treated with radiation therapy. In addition, he's a site PI of a phase 1 study to assess gene therapy treatment via adeno-associated viral vector in subjects with radiation-induced parotid gland hypofunction in xerostomia. Welcome, Dr. Brennan.
Having a family member or close friend with you and hearing results of testing is very important. Having them taking good notes is equally important. After the initial shock of hearing the diagnosis, everything else will be a blur in your spinning head. Don't be afraid to ask the doctor to repeat everything they said. Survivorship for head and neck cancer patients begins before the actual treatment plan begins. It is essential to know that your mouth, gums, teeth, tongue, and oral tissue are in good health, and if not, that corrective action is taken before treatment begins. A thorough checkup and evaluation by your family dentist is a must. Discussions about types of toothpaste, oral rinses, fluoride gels, mouth guards are just as important as getting any cavities or loose teeth or dentures resolved. Continued care throughout treatment is crucial to prevent infections. Ask your dentist for a referral to an oral surgeon experienced with head and neck cancer patients should anything above the ordinary result from your treatment plan. A thorough physical by your primary care doctor should be done if one was not done prior to your testing for diagnosis. A speech and swallow evaluation by a speech-language pathologist can set the baselines for swallowing issues, speech patterns, and volumes. They also will give you a list of exercises to do while in treatment to reduce the possibility of post-treatment issues with jaw or mouth stiffness. Continued swallowing exercises during treatment, especially if you are using a feeding tube, will lessen dysphagia or other issues. Again, have someone with you to take notes and help clarify in the instructions. Building your team for long-term survivorship. Ear, nose, and throat specialist, sometimes referred to as an ENT, medical oncologist, chemotherapy, radiation oncologist, head and neck surgeon, oral surgeon, dental, speech language pathologist, sometimes referred to as an SLP, primary care physician are your team. Please provide them with a full contact sheet of each member, full name, title, address, including zip code, office phone number for physicians, fax number, email address, website address. This team will be your lifeline forever. Clear communication and coordinated care are essential to your survivorship. Your treatment plan is your plan, built to your diagnosis and individual overall health. It is unique just as you are unique. Every alternative therapy or supplemental drug or over-the-counter product suggested by others should be thoroughly discussed with your team. During treatment, Keeping your mouth healthy is a key priority. Issues arising from treatment can not only affect your mouth, but also your overall health. It is referred to as oral systemic health. It can actually inhibit successful treatment of your cancer. 10 steps to a healthier mouth during treatment. Number 1, check your entire mouth daily and alert your healthcare team immediately of any changes. 2, brush your teeth, tongue, and gums every 4 hours and at bedtime with a soft toothbrush and fluoride toothpaste for sensitive teeth. Floss daily and contact your doctor if bleeding occurs. Rinse your mouth several times a day and before and after meals. Number 5, avoid alcohol-based rinses. Use the baking soda saltwater rinse instead and adjust the salt to your taste. Wearing dentures that fit properly and leave them out when possible to expose your gums to air. Use scented, non-oil-based lip balm, especially when out in the sun. Set the goal of drinking 64 or more ounces of caffeine-free, sugar-free beverages a day, preferably tap water. Avoid alcohol and all forms of tobacco. And find a dentist with experience treating head and neck cancer survivors. Ask your family dentist or radiation oncology office for a referral. Some of the oral effects of treatment can be dental caries, oral mucositis or mouth sores, hyposalivation, xerostomia, dry mouth. They're all the same thing, just different terminology. Thyroid issues, tissue necrosis, osteoradionecrosis, dysphagia, that is swallowing problems, periodontal disease, taste changes, trismus, Ludwig's angina, mask mouth. Mask mouth is a new COVID problem. Managing complications of treatment. Who do you call first? A word of warning. Doctors give the Reader's Digest answer, and nurses give the Encyclopedia Britannica answer. Who are you going to call and ask for? Actually, the most relatable doctor to the issue. If it's dental, call your dentist. If it's radiation related, such as skin issues or dry mouth, call the radiation office. If it's fatigue and stomach issues, usually that'll be your chemotherapy that's causing that, so call your medical oncologist. Self-care. The best source for information for self-care is not Facebook, nor is it Google. As I stated earlier, your treatment plan is unique to you. So what someone else's plan was doesn't apply to you. Read all the literature your doctor sent home with you, and if you can't find the answer, call them. Be diligent in following all the exercises, nutrition, lifestyle changes, and medicine schedule they provided for you. There are some great alternative treatments. However, they are not for curing or healing cancer. Alternative treatments for side effect management can be good, but only with consultation and approval from your team of doctors. They should be discussed with every member of your team to ensure your safety and have no adverse effects on any part of your treatment plan. Oral systemic health is the connection between oral health and overall health. Countless studies have demonstrated oral systemic links between oral health and diseases such as heart disease, diabetes, stroke, dementia, and rheumatoid arthritis. Once you have finished treatment or transitioned to a maintenance therapy program, you need to work with all your doctors on your survivorship plan. Discuss with each one and write it down. How often do you want to see me? Schedule it now. What medications or therapies will I continue on? What testing needs to be done and when? Schedule it now. What referrals are needed for rehab, such as speech, swallowing, dentures, or other oral appliances? In summary, be alert for side effects that may develop long after treatment ends. For some survivors, completing active treatment may bring a particularly challenging time in their lives to a close. Side effects may disappear within weeks. Other survivors, however, experience late side effects or dental conditions that can develop months or even years after treatment ends. Continue your regular cancer checkups and health checkups for life. Thank you.
So hello, everyone. What we're going to talk about today is why to consider the mouth in the setting of oral cancer. So many of you are survivors and know right from the beginning, dentistry and oral health becomes part of the mix. And that's for a plethora of reasons. Maintaining oral function within the head and neck space is important for overall health, nutrition, maintenance of aesthetics, and psychological issues therein, but also it's important to have a dentist as part of the team so that there's an approach for optimization before any head and neck cancer therapies such as radiation, surgery, or chemotherapy, as well as an eyes-on approach of frequent recurrent appointments so that there's early detection of disease or metastasis. So I'm going to spend a little bit of time today kind of touching on what some of our survivor Hank had mentioned in his story of his survivorship and what he has gone through and risen above and is able to share today. So many of the things that are important in oral cancer survivors are, excellent education in oral health instruction because of the high risk of dental decay, dry mouth, opportunistic infections such as fungal infections, sequela of radiation therapy such as trismus, and the lifelong risk that persists for other conditions such as osteoradionecrosis. Next slide. So many of the complications of head and neck cancer therapeutics come from major categories such as radiation therapy, as well as chemotherapy. So I'm going to spend a little bit of time talking about the major changes that a lot of our head and neck cancer survivors experience with regard to salivary gland hypofunction or reduction in saliva and the kind of dry mouth that patients experience. Many of our survivors have a plethora of diagnoses, but we see irreversible changes in the oral environment with as little as 25 gray a dosage of therapy. And to put that into context, some of our definitive treatments for head and neck cancer therapies for stage 1 and 2 cancers are treated at an upwards of 60 to 70 gray. So the majority of head and neck cancer patients treated with radiation will have some of these sequelae. So the things that we'll go over briefly are dry mouth and that decreased saliva. We're going to talk about the alteration in taste that patients experience, the oral discomfort, difficulty eating, dysphagia with swallowing, adaptation to things like a feeding tube, as well as some other sequelae that are perhaps new with those changes. And some of these are pictured within the slide themselves, such as a change in the viscous nature of the saliva. It's totally different, as well as things like hairy tongue, which although benign are quite shocking to the individual. Next slide. So one of the major things as a dentist myself that is important to me when a patient comes to me early on after their cancer diagnosis is really education. So talking about the changes that are known to be coming, especially with things like radiation therapy and how to prevent them. And the number one thing that we try to combat is dental caries, because in the setting of a dry mouth, dental caries become rampant and they really impact the overall health of the individual, the maintenance of teeth, which therefore have down the line sequela as far as maintaining nutrition, aesthetics, and all of those things. These are pictures of what we call apple core caries that we see in head and neck cancer survivors, which are very fastly progressing dental cavities that kind of eat away at the tooth and leave what we call an apple core like remnant. So that's where that nickname comes, but it's very common and something that we hope to prevent, so we're not chasing it in a lifelong survivorship pattern. Next slide, please. So some of the things that we talk about are how to prevent dental decay, or caries, as we call it in dentistry. So the majority of that comes with frequent visits and patient compliance. So you will be counseled, if you haven't already been, if you're earlier on in that journey, about the importance of maintaining a relationship with the dental team as part of the medical team. And we like a really big eyes-on approach. So initially you may be recommended to come for more frequent dental visits every 4 to 6 months, even in the first few years after diagnosis, treatment, and management, as well as adjunct therapies such as at-home fluoride care nightly, 20 to 30 minutes a day in trays or in other modalities, so that we're constantly bathing those teeth into nutrients that will help combat that drier mouth. Next slide, please. The other thing is we really want to identify patient habits or predisposing factors for other things that we know very well are high complications of a drier mouth in the setting of radiation therapy. So things like oral candidiasis or opportunistic fungal infections are really important for your dentist to be able to recognize, as well as counsel you about. So for example, if you're a denture wearer and you're new even to a prosthesis, we really want to make sure that the prosthetic is kept clean, and that we identify things like fungal infections and how to prevent them, such as never sleeping with a prosthesis at night. Next slide, please. Many of you may discuss with your both medical team and dental team the option of, saliva increase through pharmacology. And there are sialagogue therapies out there, medications that you can take systemically to try to increase the flow of saliva in the mouth. However, they only yield about a 50% positive response rate. And oftentimes the trade-off isn't as successful in the patient's eyes, because there are other side effects of these medications. They act on receptors that are not exclusive to salivary glands. So you can see increase in things like sweating or predisposition to diarrhea. And so sometimes the trade-off for a little bit of increased flow in saliva isn't acceptable to the patient. But next slide, please. The other thing that we want to be really conscientious about is education upfront in the setting of radiation therapy to the impact the radiation beams themselves have on things outside of cancer cells. So as we know, radiation therapy has come a long way. Many of you may have experienced things like IMRT, or intensity modulated radiation therapy, which are quite wonderful medical breakthroughs, and that we can target radiation beams to kind of conform to the tumor themselves, but they're not without scatter to neighboring tissues, such as the muscles that support the head and neck, the mouth, the function of the jaw. And so with that, we see kind of a change in the elasticity of the muscles, and that's known as trismus, or kind of an increased capacity to open to what was normal prior. And so when we see that, we definitely want to counsel a patient even upfront before it happens as to exercises that can be done, physical therapy that we can engage with, and monitoring of the opening of the oral cavity, because ultimately we want to be able to maintain nutrition. We want to be able to maintain, from a dental perspective, access to the teeth so that we can treat anything that needs to be treated, such as a dental cavity, so that we are not faced with the potential of something like extractions. Next slide, please. Because ultimately, one of the biggest lifelong risks of things like radiation therapy are the potential for osteoradionecrosis, or ORN, and that is a lifelong change to the bone, which the radiation beams that scatter to neighboring tissues such as bone may decrease the amount of blood flow to the area, and in turn oxygenation to the area. And with poor oxygen comes poor healing. So we don't want to have to extract a tooth in a patient that's had head and neck radiation, especially at high doses, because of that risk. And it's somewhere between 3 to 10% of patients who may experience this, and it may even be spontaneous. So we really want to optimize the patient beforehand, do any extractions prior to radiation therapy, and then thereafter monitor for the oral health of the patient so that we don't have to increase our interaction with this potential risk. Next slide, please. As Hank has discussed in his treatment, sometimes there are modalities that can be implemented by the dental and medical teams to help reduce ORN risk if it is something that in fact is an unavoidable medical or dental intervention. So if an extraction is needed, some providers go with hyperbaric oxygen therapy, which are prescribed doses of high pressure oxygen to the individual to try to increase what has been lost from that radiation. And so it has some limited evidence and often regional protocols for use, but it is a modality of care that's out there to talk to your team about. Next slide, please. And this is just a schematic of what dead bone, or kind of the ORN clinical manifestation, looks like. It's exposed bone, it doesn't heal, and oftentimes it has to either be removed or totally debrided in a surgical means. Next slide, please. And lastly, I just want to touch about common complications that many of you may experience or have experienced with regard to chemotherapy. The one thing about chemotherapy as opposed to radiation therapy is that a lot of the side effects are transient, in that they happen after the chemotherapeutics have been distributed to the body, have done their work on the cancer cells, and we see cells that turn over rapidly, like hair cells, like oral tissues, break down, and that's ulcerations in the mouth known as mucositis. Next slide, please. But as many of you know, or will come to find out, with the support of a medical team and a dental team, you can receive palliative care to help maintain your ability to eat and your ability to recover with a positive attitude, certainly, with support from a team. We know that these lesions begin 5 to 10 days after chemotherapy and persist often for 1 week or 2 weeks afterward. And as your cells rebound, so do these tissues start to heal and the mucositis decreases. So it is something that is out there that I certainly don't want to disregard, because it is quite a hurdle for our patients to go through, but it is transient in nature. And I think that's one of the most important things to remind you of. At this point, I'm going to hand over the mic to my colleague, Mike Brennan, who's going to further discuss some head and neck cancer rehabilitations.
Okay, wonderful. Thank you, Dr. Linder. So I'm going to first talk a little bit about maxillofacial prosthodontics, as far as some options for head and neck cancer patients who need to go through after a cancer resection, if they need replacement of certain anatomical areas because of the resection. And some common prosthesis can be artificial eyes, nasal prosthesis, palatal obturators, ears, and it's not uncommon. A resection might include part of the jaw, and sometimes there can be some replacement for function. And so let me go ahead with the next slide. And first thing we'll talk about is nasal prosthesis. So if the resection includes part of the nose, then these are wonderful options. As you can see here, the retention can be obtained with an implant, and sometimes they'll use a magnetic adaptations to the prosthesis that can actually have it stay in place a lot better. You see a nice outcome here as far as for a patient who had to go through cancer resection of the area. So we go next slide, please. And here is an example of a palatal obturator. So in this, we have a patient who had cancer going up to the sinus, and a nice obturator then can be made that can fill in the space. And you can see the really nice aesthetic outcomes after insertion of this obturator. Really nice smile line that we end up with this particular obturator. Next slide, please. And ear is with a cranial, we can do implants at the surgical site. Here's the prosthesis for the ear, and really nice anatomy. You can see the very nice aesthetic outcome from in this case. So we can do the next slide. And with a mandibular resection, sometimes we can have, if we have an area that can be replaced by a mandibular partial, sometimes we can replace that. And so you can see here a nice prosthesis can be inserted to replace missing teeth. So another nice example of options and with maxillofacial prosthetics. Okay, next slide. Next, I want to talk about an NIH-funded study that was completed. Now, with this particular study, it was a multi-center study of 572 patients who were diagnosed with head and neck cancer, and they received radiation therapy for their cancer. And so the patients that enrolled in the study were evaluated before the radiation, and then every 6 months until 2 years after radiation therapy. Now, there was a renewal of the study, and so patients from this original cohort will be coming back at around 7 to 8 years after radiation also for another examination. Next slide, please. So what I want to do is I want to go over the main findings, and part of to show these findings is we have to really have a good understanding of how the frequency, how often do these things happen after radiation therapy. And importantly too, is we need to understand what are the risk factors for these things happening. If you can get an understanding for the risk factors, then you're able to, if it's a modifiable risk factor, it's something that you can actually look at to change to improve outcomes. And so that's the importance of doing these types of observational studies is you first need to understand the scope of the problem, and then to understand what's leading to the risk factors that's making these more common. So let's start off with tooth loss. It's an important outcome. About 18% of the teeth in this particular, from patients in this particular studies, they were lost within 2 years. So about 18% of teeth were lost after radiation therapy. And the important risk factors that we found is that if you started at the beginning of the study with fewer teeth at the start, you're more likely to lose more teeth. And so what that means is if someone has a history of losing teeth even before the radiation therapy, for instance, they had decay or they had if their teeth were loose with periodontal disease, those patients were more likely to lose teeth before radiation even. And if you started with less teeth, then you're more likely to lose more after radiation. Patients who had a greater reduction in salivary flow rates from the baseline, so that means that they would have had a bigger impact from radiation and had less salivary flow, they actually lost more teeth. And importantly, patients who were less compliant with brushing their teeth and flossing daily, those patients were more likely to lose teeth. It makes sense, but it's important to show that the importance of having routine oral care and to maintain your, it's very important to maintain your teeth after radiation therapy. Another main finding was that with more recession of your gums, there was increased decay on these areas of bigger recession. So, and typically they're in the front of the teeth. That's what the facial buccal means. It's the front part of the teeth near the gum line. These areas had a much higher rate of decay if there was higher recession with these teeth. The next main area that we looked at too was osteobrating necrosis. So as you can see here, that exposed bone, meaning that there was an area of bone that was present, that was exposed, was around 6% of participants had this. And confirmation of osteobrating necrosis is, the difference here is if it's been present for at least 6 months, then it was considered to be osteobrating necrosis. And it was around 3.1% of patients experience osteobrating necrosis within the 2 years after radiation therapy. So it's more common in the mandible. Higher RT dose meant a higher risk of developing exposed bone. So patients, also other risk factors, if you had to get teeth extracted prior to radiation therapy, actually those patients had a higher risk of developing osteoarthritis necrosis. And current smokers, if you were using tobacco, that actually increased your risk also. So we can do next slide, please. And two other main findings that I'd like to discuss from the ORAD findings is the amount of stimulated salivary flow that someone has. So it was greatly reduced by 6 months. So because of radiation, it was 37% of what the amount started with at 6 months. There was a slight recovery by 18 months after radiation therapy. So by about 18 months, it was about 60% of where it started. It didn't come back to normal. And so, but there was some recovery from the 6 to 18 month time periods. And so patients who had more salivary flow loss, they had greater changes in complaints of dry mouth, feeling of sticky saliva, difficulty swallowing, and more problems with mouth opening. And the other main finding is dental decay. And so there was an increase in dental decay after the first 2 years after radiation therapy. And it was, so you're less likely to get decay if you used daily fluoride use, prescription fluoride use. You maintain good oral hygiene, you're compliant with hygiene. Patients who had dental insurance were less likely to have dental decay. And those patients that had greater in high school education actually were less likely to have dental decay. So we can go next slide, please. So just summarizing everything that we talked about. So we know that there's a lot more patients surviving head and neck cancer diagnosis. Treatments have improved survival. Oral health is an important factor when considering overall systemic health in this population. And prevention and education are essential in achieving oral stability in patients, head and neck cancer patients. So as noted earlier, creating a multidisciplinary team, including your dental practitioner, is really important for a comprehensive approach to patient care. So we go next slide. So just some key points. Close follow-up, it's really important with your dentist, especially in the first year, because that's when dental decay, you want to catch it early. So there's not trying to catch up and trying to get your teeth back to where they should be. And oral hygiene protocols are really important as far as compliance with brushing, flossing, prescription fluorides, compliance. So it's applying it either through rinses, gels, with or without trays. The most important thing is that it is applied consistently. Xylitol, artificial saliva or sugar that can actually help fight decay. And also fluoride varnishes, chlorhexidine are another options. And dietary counseling is also really important. Avoiding certain types of sugary substances is really important. So next slide. And just some examples of really nice resources as far as for oral care and patients that have gone through head and neck cancer. And these are just some nice information sources. Okay, and I think then the next slide then. And just a couple of pages of references. And next slide. Okay, perfect. So we'll go back with Dr. Kirk.
Thank you so much, Dr. Brennan. I would like to thank all of our presenters for their experiences and insights. At this point, we welcome questions either by the chat or through the Q&A box. So while we're waiting for the questions to be submitted, I'll start with a few of my own. Dr. Linder, what is your thought on the commonly prescribed over-the-counter oral preparations such as biotin?
Yeah, so I think they're great resources, but they do have limitations, and their effectiveness is sometimes case by case, patient dependent. I think for patients that like them, they use them frequently. I know things like the Biotene oral rinses are a favorite of some of my patients, as it does give that wetting sensation to the chronically dry mouth. But I do have other patients that kind of leave them behind and just move on to other things. So a little bit of situation dependent, but for over-the-counter products, I do believe it's one of the better options to at least try. And they come in a variety of different formulations. So there's Biotene oral rinses, different toothpaste, and other products out there.
That was my next question, actually. Do you have any particular preference for different types of formulations? There's gels, there's liquids. Is there one that you think is more successful than others?
Dr. Brennan can chime in on this too. I find with my patient population, the oral rinse is probably the favorite of those that like the products. That in combination with other like Sensodyne products and other things that are going to be a little more gentle on the oral environment, I think are probably the winner in my clinic.
Great. Dr. Brennan, do you think there is such a thing as too much or too aggressive mouth care? I've seen some of my patients come in with abrasions on their tongue from brushing their tongue too much. What's your advice there?
Yeah, certainly. So I think there's always a fine line of too much. I would say as far as the teeth, I mean, one of the issues that can happen if you're too aggressive is increasing recession. And one of the things that we found in the ORAD study is as more recession happens, there's more risk of dental problems happening as far as tooth loss and tooth failure, for instance. And so I think it's just being mindful of that and not. You definitely want to be brushing at the gum line, but not being too aggressive, because if you don't, then more problems happen from not brushing at the gum line. So it's just trying to find the right amount. Now, as far as is with the mucosa, I actually recommend for everyone to use a tongue scraper, but you can be too aggressive with that too. But I think it works better sometimes because when you have less saliva after radiation, things can just build up on the tongue, and then you can have problems just from that. So I actually recommend, and I use a tongue scraper twice a day. And so just using a tongue scraper twice a day, in addition to brushing your teeth, I think it's really helpful to really cleanse out the mouth. But I think those are, there's always a fine line with everything. And I think it's just trying to keep the mouth cleaned out as much as possible. Both the teeth and the mucosas is important.
Great, wonderful. I guess it speaks to the close relationship that's needed with the dentist and the importance of this session. My final question before we go into the questions that are starting to pour in, do you think there's a role for acupuncture for salivary production? Mr. Deneski certainly alluded to that already in the chat. And I think in the previous session, someone else also suggested that it was really helpful for them. What are your thoughts on acupuncture? Have you seen success of that in your own practices?
Sure, I can address that. I definitely think acupuncture, I've had a number of patients have had success with that. I think it's one of those you got to continue to do. So it's one of those where if you start acupuncture, you get some benefit. It's just to continue on with it. It's not a long lasting, but once it works for some people, it depends on how much functional saliva you have after radiation. So that it depends on the residual function, how much saliva you can produce. And so that is an important factor when it comes to acupuncture, but definitely I've seen some benefit.
Yeah, I agree. Oh, sorry. No, I was just going to say, I agree. And it's just, I think a little bit of it is managing expectations, depending on the degree of, like Dr. Brennan said, depending on the degree of salivary loss that you have. Sometimes you get an increase, but it may not be fully to the extent that the patient hopes for, but there can be some definite positives to it.
Great, that's wonderful. Mr. Deneski, do you want to share your experiences with acupuncture as well?
My first treatment was almost 5 years after my last treatment for radiation. I had 42 radiation treatments. So I had a very high dose of very dry mouth. I was fortunate. My speech therapist did measurements as to what my saliva was before I started treatment. So we knew what my baseline was. And when I went to see the acupuncturist the first time, I was at 15% of my baseline. 90 days after I came back from that first set of treatments, my saliva had returned to 85% of my baseline. And I've been able to maintain that, being retreated every 5 months. Each individual is different. It works for some, it doesn't work for everyone. But once you have to watch when you start to feel your saliva leaving, you need to go back for a retreatment. And I must stress, medical acupuncture. Do not go see just a general acupuncture guy down the street. You want to find somebody that's medically certified in their state and someone that is familiar with the protocol for it. And if anybody wants it, I can give it to you. It's a radiation oncologist, retired Colonel U.S. Air Force, and he does medical acupuncture as his practice now.
Yeah, great. Great points. And also a great point in that, you know, when you're finding providers, make sure they have experience with head and neck cancer. So we'll jump into the questions now. Some of these were already answered by Dr. Linder, but just so that they get a wide audience, I'll start from the beginning. The first question was, I had a tooth fallout due to osteoradionecrosis and a piece of jawbone is presently exposed. What is the treatment for an exposed bone? Do you have to do a skin graft?
Yeah, so I answered this one in the chat, you know, and it calls a little bit to the presentation we gave, but it definitely definitely depends on the degree of bone exposure, whether that piece of bone is fixed or not. So my advice is to contact the dentist immediately if you haven't already. And there can be very conservative local management with either removing a piece of mobile bone, antibiotic regimens, rinses, and then obviously if imaging is taken and it's a much broader problem, then sometimes more aggressive surgical means are implemented. So it's very case dependent, and definitely loop in your dental team if you haven't already.
Great. Second question, what is the best treatment for osteoporosis for head and neck cancer patients? And there's another part to that question. The drugs to treat this can cause osteoradionecrosis. What do you recommend?
I can address that. I think you do have to be really careful if you happen to have osteoporosis that needs to be treated and you've received radiation in the head and neck region. Just from receiving radiation, you're at increased risk of osteoradionecrosis. But then if you add a bisphosphonate on top of that, now you have two things that can impact the risk of getting osteonecrosis. And so we've seen some patients that have had radiation for head and neck cancer, then they have to be treated for osteoporosis with bisphosphonates. And the issues that they've had with osteonecrosis, now it's osteoradionecrosis as well as medication-related osteonecrosis of the jaw. So you add those two together, it is quite a risk. And so I don't know, you have to be very careful as far as making the decision to go on bisphosphonates after you receive radiation. Now, bisphosphonates have a huge advantage, though, as far as decreasing the risk of hip fracture and some of the other fractures that you get from osteoporosis. And so they actually work, but it's just being really careful and having that conversation with your primary care doctor or whoever is going to be managing your osteoporosis as far as taking on that additional risk.
Definitely. And I think also working very closely with an endocrinologist that is also well in touch with, you know, head and neck cancer patients as well is very helpful in that setting. Mm-hmm. Third question, actually, can dental work be done to replace teeth, or dental work that's done to replace teeth be considered as medical necessity versus elective? And this is in the context of Medicare coverage.
Mm-hmm. Yeah, so I touched on this a little bit. Again, this is one of those ones that I hate to call back and say it's case dependent, but it really depends on, you know, the state you're in, the coverage that you have, the program that you're on, what insurance you have, if you have any private insurance. I can say that replacement of lost teeth due to oral or head and neck cancer can be at times covered medically. Some procedures better than others, but it involves, you know, team participation, the essential documentation by all the providers, and it does have its limitations, and it can be a little bit of an uphill battle. So it can be done. It's more limited in Medicare and Medicaid than some other private insurance groups, but I would definitely kind of loop in everybody in the team and see what they can get together for, you know, letters of medical necessity and whatnot, because it's worth a shot.
Fourth question, what else should I drink besides tap water? Sparkling water, coffee, tea? I think I saw Mr. Deneski mention that, you know, he was using fruit juices. I mean, those things obviously have high sugar content, but are also nutritious as well. What are the best things to drink?
So yeah, it's a balance between the nutrition or the calories that you may need versus mitigating that risk for dental decay. So obviously a dentist in any environment, whether head and neck cancer or not, hears fruit juices and they kind of, you know, recoil a little bit. But, you know, we have to be realistic as far as if you need calories, things like smoothies, you know, if swallowing's in place is a great way to get some calories in. And they're obviously often juice or fruit or vegetable flavored. But I think that from a decay reducing perspective, we like things that are, you know, plain water, you know, carbonation. Patients often don't think that carbonation can predispose you to dental decay, but actually the pH of anything carbonated, like a sparkling water or a soda, can be put you at a little bit higher risk for decay. So, you know, things like sugar substitutes, flavorings for water and things like that might be best. You know, coffee and tea without sugar, creamer in it is always a good option for caffeine and a little bit of normalcy for everybody, but, you know, everything in moderation. And if you do have something with sugar content in it, you know, as immediate brushing and rinsing as you can do really does pay off.
Mr. Deneski, do you have any comments on that and your experiences?
No, again, with the fruit juices, again, it was more of a caloric thing. My weight loss was rather great. I was on the feeding tube for 18 months. So a lot of complications there. Black tea was probably the only other thing, either iced or hot, without sugar, maybe a little bit of lemon with it, but that was about it. But tap water is much more healthy than bottled water.
This is another question coming from a gentleman. I have SCC of the alveolar ridge and hard palate. I'm sorry to hear that. All my teeth were removed before surgery. Will I be able to have teeth again?
Yeah, I guess I can. It depends on how much had to be removed as far as when they removed the cancer with the cancer resection. So it's hard to answer that for sure that you can. It depends what's left, and so it depends on how many teeth are left. As far as if you could do partial dentures, that could be hooked onto the teeth that are remaining. Yeah, I think that's one as far as that a dentist would need to look at the radiographs and see what's remaining to really make that determination. So I can't answer it a definitive yes or no with that. It would have to be evaluated a lot further to see if it's possible.
If you haven't yet had surgery as well, it's good to have that discussion with your surgeon. They might be able to incorporate that into some of their preoperative planning in terms of the bony stock that they take for the reconstruction. So definitely a good question to incorporate into your preoperative list of questions that you may have. So sixth question, how do you deal with caries decay if you have trismus after double radiation? My dentist can't reach the back of my teeth.
Mm-hmm. Yeah, so it's a challenge, and that's why we're so upfront about preventative measures. However, it does arise. So I would say trying to, not that local dentists and providers aren't great, but trying to incorporate a provider who may have more experience with head and neck cancer survivors. Sometimes just different modalities of treatment. We have smaller dental hand pieces to access care depending on the extent of trismus. Occasionally we'll take a case to the operating room if something really has to happen. And sometimes, in a university or in a larger hospital setting, there can be a multidisciplinary dental team approach to trying to maintain things. And sometimes we do things a little out of the ordinary. So we could root canal a root tip and, amputate a crown that you may see and kind of seal it over. So there's some things that can be done, but definitely incorporating some team members who are used to working with patients with trismus, I think would be a good starting point.
Mm-hmm. And I guess one other thing to add is prescription fluorides are so key as far as prevention. And so it could be a brush on. It doesn't, if you're unable to use a tray, you can't get impression. At least getting a brush on prescription fluoride with those teeth is important as far as to prevent dental decay. So I think that's really important to prevent problems.
This is a popular question, apparently. Are there any resources to find a dentist that is familiar with head and neck cancer issues and how to deal with them?
Yeah, so I addressed this a little bit in the chat. I said start with your head and neck team already, because oftentimes at a hospital setting, they're already familiar with those in the community who they may work with as part of their planning team for things like Dr. Kirk mentioned, preoperative planning, tooth extractions, what bulk of bone may remain. So that would be a good starting point because they would know who in the immediate area may have some training and familiarity with it.
Mm-hmm. Definitely would agree with that. It's not something that is easily found online, but something that's easily found with the help of your head and neck surgeon. Xylitol, I think you touched on this in your talk, Dr. Linder, but xylitol gum and Dr. Brennan, xylitol gum or Xylemet's effective in producing functional saliva? Good question.
Yeah, I can. So I've actually found that to manage a lot of the dryness at night, because that's a big problem for a lot of patients. Just having a dry mouth at night and waking up a lot of times just because of that. The Xylemelts can be very beneficial, and I actually use them every night myself. I'm a mouth breather, and I get a really dry mouth myself, and so Xylemelts are wonderful, and most of my patients who use them do like them. Not everyone does, and that's with any dry mouth product. You got to try it, and you'll guide someone to try a product, and they'll say that was terrible. Who would use that? Then the next person will say that was fantastic. It really helped. And so I think you just gotta you have to try things to see what you like. Now I guess sometimes you have to be careful with xylitol gum or gum in general. It can lead to TMD type of symptoms. So pain with the temporomandibular joint and the muscles of mastication. As far as out here, you can get pain. So you do have to be mindful as far as using too much gum, because that can be pretty, that might help with the dry mouth, but it can lead to other problems. And some people with using a lot of xylitol can actually cause some GI symptoms. So you do have to be a little bit careful, but it helps fight dental decay, xylitol. So there's a lot of benefits with it, but you do have to be mindful how much you're using.
You have to love a dentist that does the treatments to themselves, like the tongue scraping and the
Absolutely.
FYI, I've also scoped myself several times, so I've also done a similar thing. So I can sympathize partially. So next question: is there any recovery with respect to jawbone health over time? Do risks for implants, etc., diminish 5 or 10 or more years out? So 5 years out, you can worry about the risk of obviously recurrence, but do the other risks, dental risks, go away at that stage too?
Mm-hmm.
I can start with this one. It's a little bit, this is my answer for everything. It's a little bit dependent on the situation, but really the dose of radiation especially is one of the main factors we consider. Certainly the risk of radiation above some of the dosages I mentioned are kind of lifelong effects that we do see. And if there is an area that was not irradiated and Other areas were, that's definitely a balance that has to be struck with regard to implant planning. I know sometimes if people have a flap with a bone segment also transferred, sometimes you can see successful implants done in that, but it really is case dependent. And obviously it's important for the dentist to obtain mapping from the radiation oncologist to understand to what extent and what areas were exposed to the maximum amounts of radiation.
Mr. Deneski, it sounds like these have been ongoing issues for you, even though you've passed that 5-year window. Is that correct?
Correct. Yeah, I just recently went through another round. My original appliance that was installed in 2009 literally fell out of my mouth about 1.5 years ago. And finally, 2 weeks ago, I was able to get my new lower denture attached to the new bar and the new, that covers my mandible and the openings there. Hyperbaric, I've done 70 hyperbaric treatments between the 2 sessions. I've had collagen implants. I've had stem cell. I have BMP, bone morphogenetic protein. All of these have helped to some degree. And now I'm on a new regimen to help with the healing process. But I was able to get 3 implants replaced. One of those failed on this last go around. I have an excellent MD-DDS oral surgeon. He's well trained in this, and both my family dentist and my radiation oncologist recommended him when the first signs of severe caries, and during the first emergency surgery from Ludwig's is when we found out that I had osteoretinal necrosis to a large degree. So I've lost a good portion of my upper mandible on the left side. But it's nice to have teeth back. Now I have to go back for speech and swallow therapy to be able to learn how to chew and swallow properly so I don't aspirate. But it was well worth the journey. It's well over $100,000 at this time. That's out of pocket.
That's unbelievable. Thank you for sharing that with us. Quite frightening, really, the money that has been spent.
Could have been a summer home on the lake.
We're coming up to time, but we actually are probably going to go over time because we've received so many wonderful questions. So for those that want to stay, please do. We're going to endeavour to get through all of the questions. If those want to leave, you feel free to do so. So do you prefer fluoride gel or paste, trays versus brushing? If trays, for how long and how often?
Yeah, so fluoride, yes. So the ideal thing with fluoride is exposure. So I think kind of the gold standards that it has been for years is if you can get either custom trays fabricated by your dentist or even an over-the-counter boil and bite sports guard can do the trick. The gel fluoride that we can prescribe is of a higher content than anything you can get over the counter, and it's held in the tray with exposure of the teeth. And we often recommend 20 to 30 minutes every day for life. So I tell my patients it's your new regimen of tooth vitamins. Do it at a time of day that's convenient to you and that you know is reproducible. So I have patients who wear it while they're in the shower before they go to bed, or if they're reading a book, or wherever you feel like you can inject it in your life. That being said, if you're not going to tolerate that, something is better than nothing. So that's kind of my approach.
In the chat, someone mentioned that they're allergic, unfortunately, to fluoride. Any other suggestions in that situation?
Yeah, I think in that situation, it's just really careful plaque control. So as far as you're talking flossing daily, you're just being really careful about brushing, could be up to 3 times a day. And so I think you just have to be, if you have an allergy to fluoride, then I think you have to be very careful about completely optimal oral hygiene to keep plaque away, and also being careful with diet, so not introducing too many sugars into your diet. So it's kind of limiting in kind of limiting, not eliminating, but limiting some of the sugars you get in your diet, because you need sugar and you need plaque source and to really develop decay. So it's trying to eliminate those things so you don't develop decay.
Yeah, maybe even consider purchasing a water pick to help with oral hygiene.
Mm-hmm.
Yeah,
Yeah.
I think someone else mentioned that in the chat as well,
Oh.
that they swear by a water pick actually and a soft toothbrush to follow. Sort of on the same line, best regimen for flossing, brushing, 2 to 3 times per day. Water pick, we just discussed that. This is a new one for me, coconut oil rinses. I don't have any input on that.
Yeah, I guess on patients, I see a lot of patients with oral lesions, autoimmune type lesions. And it's not common for people to use some type of oils. Coconut oil is one of them. And they feel like a lot of patients feel like it helps with the dry mouth as well as can help with sores in the mouth. And so I think that's just a personal choice. I don't know if there's the actual research studies to confirm that, but if it feels, if it's comfortable in the mouth, then it's worth it.
That's great. I'll take that one on as a suggestion. So what designation should we look for when seeking a dentist who has this in-depth knowledge like yourselves of post-radiation head and neck cancer treatment? So what credentials should they be looking out for in the things in the bio?
Mm-hmm.
Yeah, so I mean, it can be a little variable because I think just like other things in education, programming can be variable. Some things, I think number one, like we said, the recommendation of the other head and neck team members. But for a dental, if you can access the bio of the dentist, I guess a general practice residency and a hospital-based program is really big. A credential or a master's or PhD in oral medicine. Certainly some of our dual degreed oral surgeons, like Hank's experience, can have really in-depth head and neck cancer training. So those would be some of the starting points that I would recommend.
This sounds like a bit of a case study, actually. Patient believes he's at high risk of aspiration pneumonia, tells his dentist that he cannot have anything done orally while lying down. Patient has multiple dental treatment needs that would require lying down and use of water. What precautions need to be taken for treatment? Or if patient isn't able to have treatment at this time, any considerations for a patient like that?
Well, I guess some of the options might be just if you need to, can you see me still? If you need to do treatment more in a upright position, you may just be limited on how much treatment you could have done at one time. And they can use a rubber dam to go around the teeth. And so it kind of limits the amount of, as far as water that's in the situation. So it decreases the risk of aspiration with that. So there's things that can be done to try to kind of eliminate some of the liquids that are used when you have to do dental work. So that might be helpful. But then if you need to sit up when you're doing some of the dentistry, maybe you can go a little bit back. You would just have to limit how much you can do at one time. I think
that's an excellent point. There's also different isolation systems that can be added on. So I'm not brand loyal in any way, but there's some things called like an Isolite, which is, a combination bite block, tongue retractor, high volume suction, kind of a one-stop shop for those kinds of things all in one device. So that's just an example of some of the many products that are out there in combination or in lieu of a rubber dam. If there's absolutely, no way to proceed with any dental care in an outpatient setting, a last resort may be finding a dentist who has operating room access. They could take the case to the operating room, but, that has to be, I would think, balanced with, the financial implications of getting that covered under insurance.
Great. We're coming to the end of our session, so I would encourage any questions that want to be asked, please send them in now. Another question, I'm sure neither of you are brand loyal, but most toothpastes burn my mouth. Any recommendations for a gentle fluoride toothpaste for sensitive teeth?
I mean, I can say what I typically say for this, because I see patients that have more oral lesions, and so I'm talking more as far as sensitivity with mucosa, not as much as sensitivity with teeth. But I typically recommend to try things without anything in it. So not top shelf toothpaste, but things at the bottom shelf. And so I find that sometimes the cheaper type of toothpaste without the tartar control, without the total, without all baking soda, sometimes people can get by a little bit better with those type of toothpaste. Some people are like biotin toothpaste. That could be a little bit more calming. So that I would try those things and see how you do.
Yeah, there's Sensodyne products, and there's also Prevident, which is prescription strength toothpaste with additional fluoride in it, and there's a sensitive variety of that as well. So it's probably going to be a little bit of trial and error to see what's most comfortable.
Yeah, I think someone's mentioned biotin in the chat. Sylvia Lewis said it's sometimes hard to find, but Amazon has it. And I think the Prevident maybe Dentist 5000. No Burn for me, great stuff. It is a prescription from Warren Collins. What causes the sensation of burnt tongue? It doesn't matter what food, and I'm a year out.
Well, there could be a number of causes for a burnt feeling of the tongue. Sometimes it's just from having lower salivary flows. And so if you have low salivary flows, you have poor lubrication in the mouth. And so your tongue rubbing up against your roof of the mouth or your lower teeth can cause that burning sensation because of poor lubrication. And so the treatment for that is really trying to get more of your own natural saliva in your mouth. Sometimes it could be a fungal infection that develops. So that's always a possibility. And so those are really some of the main things that can cause some of the burning type of issues that I found. That those are the most common things anyway.
Acidic foods have a lot to do with it. I can eat a raw tomato, but once you process that tomato in any way, shape, or form, I can't eat it. It burns my mouth. Same thing with pickles. The vinegar or the solutions in pickles. Even gherkins, I can't eat those anymore. So a lot of anything with acid in it is going to be something that can burn your mouth or make that burning sensation.
Final two questions. So some cancer centers start fluoride tray with treatment, some after treatment has finished. Are there different protocols or recommendations? I mean, this might be what you're alluding to throughout the discussion, Dr. Linder, I think.
A little bit, I think to each their own, certainly. You can have probably, it's like the Trident commercial, 4 out of 5 dentists recommend it, right? So there's definitely variation there. Sometimes what I tell patients is just to get used to it in kind of before all of the changes elsewhere that you might experience with radiation, to go ahead and get used to wearing it ahead of time and just kind of get into that routine. The other thing is sometimes the patients like to wear them even without the fluoride in them, because it just kind of adds after treatment, and when you have that kind of burning sensation in the mouth immediately thereafter after radiation, it kind of just lifts the tissues just a little bit off the teeth, and it's a smooth material, so it's not likely to rub or cause any sores or anything like that. So there can be a little bit of a mixed reason to do it ahead of time.
Final question. Would extractions also be concerning some years out? I still have wisdom teeth. This patient didn't get any extractions, and I assume they'll want to extract at some point.
Okay. It depends on how much radiation was in the area. So I think that's, as was mentioned earlier, that's really key, is knowing the level of radiation in the area where you want to get the teeth extracted. If it was the lower jaw, more than likely there was quite a bit of radiation. If it's in the back wisdom teeth, there likely was, but it depends. So yeah, it really depends on how much is received. Now, if there was quite a bit of radiation to the areas, it's lifelong, so that risk is always there, and so that it really doesn't go away much. That it continues to be a risk. It really depends on the amount of radiation. That's a key thing to know.
Great. So I think that brings our session to a close. I want to thank the survivors and their caregivers for their attendance. I want to thank our panelists, Mr. Deneski, Drs. Linder and Dr. Brennan, as well as the Head and Neck Cancer Alliance and the American Head and Neck Society for their time in organising and hosting the webinar. Thank you, everybody. Good night.